Welcome to the first module of the new Pinellas County EMS CME program. This is 2016 Module 1, and the topic is Medical Patient Assessment. We're going to talk for a few minutes today about some sort of back to basics in terms of medical assessment. Now, we're not going to teach you how to take a blood pressure or check a blood glucose, but we're going to talk about how to organize and approach assessment of the medical patient. Here are our specific learning objectives. We're going to discuss the mental models we use in assessing patients. We're going to introduce an organized approach to patient assessment. We're going to introduce the concept of generating and refining a differential diagnosis. And we're going to talk about the components of a history, the components of a physical exam, and some common pre-hospital diagnostic testing. We're going to review the components of making an appropriate transport decision. And we're going to introduce the concept of clinician self-awareness in patient evaluation. The first thing I want to talk about is pattern recognition versus active searching. These are two different mental models that we use when we are approaching a problem-solving situation. The classic teaching is that experts use pattern recognition. It's faster, it's easier, many argue it's more accurate, doesn't take as much thought, as much active involvement in the process. Now, that assumes that you're an expert, and many would say, well, what does it mean to be an expert? In the context of seeing patients, is it 100 patients, 1,000 patients, 10,000 patients? There's been a lot of discussion out there on this, and many people felt that you needed 10,000 hours of practice at something to become an expert, although some people now are saying it's more like 5,000 hours. Either way, that's a lot of patients. The real question is, what do I do if I'm not feeling expert today? That is, what if I'm not sure or just want to confirm what I think I might be looking at? And the answer is that you have to use an active searching mental model. You have to actually actively think about what it is that's going on with your patient and use a logical thought process to get from point A to point B. The other thing that would certainly be helpful is collaboration between clinicians. If I'm not sure what I'm looking at, well, I could ask somebody else that's there with me, and to bounce ideas off each other so that you can get to the right idea. In short, you need to use an organized approach. There's a couple of reasons why we want to use an organized approach. The first is so that you don't miss stuff. You need a place to begin when you're unsure what you're looking at. And even when you think you're that expert that knows exactly what you're looking at, you need to make sure that you haven't missed something. Having an organized approach also allows you a way to think through the case in a logical fashion. It facilitates teamwork among clinicians, as we talked about before. And it really just allows us to have a framework of how we're going to approach the undifferentiated medical patient. For those of you who are too young, that's Columbo there on the screen, a very famous television detective. In short, what we're asking you to do is use your brain when you approach a patient. Now, there's many examples out there of how you organize an assessment of a patient. And as I said in the beginning, we're not going to talk to you about how to take a blood pressure or how to palpate a pulse. That you learned in paramedic or EMT school, and we're just going to assume that you know that basic stuff. What we're talking about here is sort of the next level. How do we actually organize how we're going to approach a patient? The one I like the best, and I'm partial because I work on this program, is the Advanced Medical Life Support Assessment Pathway. It's a National Association of EMT class, so this is the medical equivalent to PHTLS, and it encourages an assessment-based approach using active critical thinking skills. It allows you to address immediate life threats right up front. It facilitates gathering a focused H&P and reasonable use of your diagnostic tools. And it accepts and promotes the fact that paramedics do, in fact, make differential diagnoses while they're assessing and treating patients. Now, that's something that you may not have heard before. In fact, you've probably heard many people say that paramedics don't diagnose. At best, you've probably heard people say paramedics make field impressions. Well, I have to tell you, I think paramedics do diagnose in certain circumstances. I'll give you an example. Take a 55-year-old male complaining of chest pain. You arrive, he's diaphoretic, he's pale appearing, he's complaining of crushing chest pain and his left chest radiating to his left arm and jaw. You take a quick history on him, you find out that he's a diabetic, he's got high blood pressure, high cholesterol, and maybe even had a stent 5 years ago. You then put your EKG on him, do a 12 lead, and you show ST segment elevation in 2 or more contiguous leads, let's say 2, 3, and AVF just for this guy. For all the world, you've just diagnosed a STEMI. There's nothing I'm going to do in the emergency room that you didn't just already do to make this diagnosis. In fact, this guy is going right to the cath lab. I don't need a cardiac enzyme. I don't need a chest x-ray. He's going directly to the cath lab. In that situation, you have absolutely diagnosed a STEMI. I don't think anybody would argue any different. Now, that's a pretty concrete example, but I think it's reasonable to state that paramedics actually do make a differential diagnosis. And we'll talk a little bit about what a differential diagnosis is here in just a minute. Here's one example of an organized approach. Now, this is adapted from the AMLS pathway. It's fairly similar. I changed it around a little bit because this, I think, will be a little bit clearer for you. It starts with what's the presenting problem? What's the chief complaint? Once you establish that, you identify and treat any immediate life threats. Essentially, you cover your ABCs. And then you stop and you do the look test to decide if they're sick or not sick. Once you've addressed their immediate life threats, once you've decided they're sick or not sick, now it's time to actually engage the brain. You want to stop and think. You want to formulate your differential diagnosis. And we'll talk again about what exactly a differential diagnosis is here in just a minute. Once you have your differential, that's when you gather your history, you do your exam, you do your diagnostic testing in order to rule things in or out from your differential diagnosis. You use this to essentially refine your differential. Once you have a refined differential, you're going to be left with a handful of possible explanations for what's going on with the patient, and you can go ahead and implement your treatment and evaluate the results of your treatment based upon that revised differential. And of course, you always are going to go back to the top and reevaluate your patient with any changes. So what is a differential diagnosis? A differential diagnosis is a working list of possible conditions or diseases that explain your patient's presentation. In emergency medicine, differentials should be ordered by likelihood and severity. That is, the more likely thing is listed before the less likely thing, and the thing that's going to kill me now is going to be listed before the thing that might kill me in 20 years. So it's a organized list of the possible diseases or conditions that explain the patient's presentation. Now, going back to our pathway, you see the first thing there is immediate life threats, ABCs. Do I need to be bagging, tubing, shocking, or doing compressions on this patient? Really, what do I need to do this very second? Remember BLS first with this, and remember that you address each life threat before moving on, just like in your rapid trauma assessment. This is very similar to your rapid trauma assessment, the initial ABCs. In a trauma patient, it might be controlling an airway and controlling bleeding. Here it's, airway, breathing, circulation. Once that's done, you go on to the look test. Now, I bet a bunch of you can diagnose a lower GI bleed from the front door. We've all been there. We know that lovely smell. And, you walk up to the house, you smell that, you go, yep, I bet he's in the bathroom. Take a look at this guy, sick or not sick. Well, right off the bat, you can see he's unconscious, and so he's probably sick. That's the look test. Anybody who's been doing this for a little bit while, sometimes people refer to it as the doorway test or the sniff test. It's just your initial impression. Is this person sick or not sick? Really important here to make sure that you give people the benefit of the doubt. Something scared them enough, something traumatic enough happened where they called 911. You want to make sure you definitely give them the benefit of the doubt. Here's a couple more examples of a look test. The kid in the upper left, he looks angry, but if he's angry and crying and resisting you, he's probably not that sick. The kid below, kind of little bit on the limp side, sunken eyes, not really engaged, certainly looks sicker. Take grandma up top. She's reading her book, looks perfectly fine. Or the guy who's face down in the snow, or maybe here in Florida on the beach. Those are two different presentations and obviously give you a different impression of what might be going on with the patient and how sick they are. Okay, so once we've gotten through the ABCs, we've gotten any immediate life threats taken care of, we've decided whether or not we think this patient is sick or not sick, well, the next move is history taking. And remember that history is subjective data. It's what the patient's telling you. Remember that the patient may have a chief complaint or they may not have a chief complaint. They may just have a presenting problem. And those are essentially equivalent from our standpoint. It gives us a starting place. OPQRST we're all familiar with for how to assess and categorize pain. And the sampler history, I wonder if you are all familiar with the R on the end of sampler. The R stands for risk factors. We'll show why that's important here in a little bit, but risk factors really help you with that differential diagnosis and refining that differential diagnosis. Next is the history of present illness, the past medical history, and the review of systems. And those are distinct things. The HPI sort of encompasses the OPQRST and the rest of what was going on leading up to this. The past medical history might be all their previous diagnoses. And a review of systems is a concept that doesn't really get taught that much in EMS, I don't think, but it's very integral to patient assessment and history taking for physicians and nurses. Review of systems really means I'm going to ask some very pointed questions covering each organ system to see if I can uncover related or associated symptoms that might help me to narrow my focus down. Social history is obviously also important. If the patient is using illicit drugs or is a heavy drinker or a smoker, those certainly impact the potential differential diagnoses that we might be looking at. Remember to include family and caretakers. They often have extremely valuable information. If the patient gives you a medication or condition that you don't recognize, you really need to ask them what it is or look it up. Do not assume that you know what the medication is if you don't really, and certainly do not admit it just because it's something you haven't heard about. The final and probably most important thing I want to emphasize on history taking is you must get at least the basic history, that is past medical history, medications, allergies, just the very basics. You really need to get that as soon as possible before your patient becomes unconscious and can't give it to you anymore. We see this all the time. If you go, say, in the trauma bay, you'll notice that there's a rapid fire number of questions right off the bat when the patient gets there, and it doesn't have to do necessarily with how fast you were going and were you wearing a seatbelt. It has to do with, are you allergic to anything? Do you take any medications? We need to know those things in case we have to give emergent medications there. Once the patient begins to be altered or lose consciousness, you're really unable to get that information, and that can severely hurt your ability to take care of the patient. Briefly talk about how to ask questions. There's a few things we want to remember about this. Questions should be open-ended. You don't want to be leading the patient. You want to ask one question at a time. If you ask a string of questions, the patient will often only answer the last one. They might leave out one or two, and you'll never come back and get the answer. You want to offer multiple choices when you ask somebody to characterize pain. If you say, can you describe the pain, you should then say, is it sharp, dull, pressure, aching, burning, and give them a number of possibilities so that they understand what you mean by describe the pain. You can certainly also ask clarifying questions when needed. Don't forget to consider your nonverbal communication, both what you're giving off as well as what the patient's giving you. Extremely important. And we all know the difference between somebody who's leaning back in their chair with their arms folded, who wants to hear nothing of what we have to say, and somebody who's intently, actively listening to us. Also remember, it's okay to ask why when a patient gives you their interpretation of a cause for a symptom or condition. If they tell you this is what they think's going on, a very good question is, why do you think that? What makes you think that this is your asthma acting up and not whatever else it might be? Patients' insight into their own condition is often very useful. And finally, don't get angry, frustrated, or impatient. Remember that you're asking questions that the patient may not be expecting, they may not think are relevant because they're not the medical expert like you are. So it's very important to be patient with your questioning make sure that you don't get yourself frustrated by the pace or by the patient's inability to give you the answers you're looking for. Physical exam. This is old school, I know, but it's critical. You need to collect objective data to verify, to confirm, to disprove things that the patient has told you. Now, in this section, we're going to review some very basic components of the physical exam to point out some things to key on. But we're not going to talk about, again, how to take a blood pressure, how to palpate a pulse, etc. That's stuff that we assume that you already know. We will discuss tailored exams by organ system and by presenting problem in future CME models, but today we're just going to review some basics. So a couple of key points on how to examine patients. You want to be examining on bare skin whenever possible. And remember that your goal is to find things. You're a detective. You don't want to say it's just negative or normal. The whole purpose of the physical exam is to actually find things out. Remember to protect patients' privacy and modesty whenever possible, but remember that your job is to search things out here. Missing an injury, missing a finding, just really unacceptable. The whole point of doing a physical exam is to make sure that nothing gets missed. And we'll go through a couple of organ systems here. We'll start with neuro. A few things we want to make sure we get on every neuro exam is a level of consciousness and a GCS. Understand the difference between those two things. We want to remember the difference between a focal and a general neurologic finding. Now, this is something that may not have been introduced to you in paramedic school, but I think it's extremely important. The picture on the bottom right here is showing the motor cortex of the brain, and you can see listed from top where it says toes all the way to the bottom where it says lips and tongue, that the motor distribution for the brain is organized in a fashion along that precentral gyrus there. And that is actually the individual pieces of brain that control motor function. So you can imagine that a focal injury there to one part of that brain would cause a focal neurologic finding, that is, a particular part of you that doesn't work. Now that's very different from your whole brain is being squished or squeezed by a bleed or trauma or whatever it might be, where you have general neurologic findings such as altered level of consciousness, such as seizures, posturing. Those are general findings, and it's very, very important that you distinguish those from focal neurologic findings. If you think about our MEND exam or our FAST exam or whichever one we're doing, the LA stroke score, whichever one you might have heard, the whole point of those exams is to find something that's asymmetrical or something that is focal in nature. It's one side. My one hand doesn't work. My one leg doesn't work. This side of my face doesn't work, which again is very different from I'm having a seizure or I'm unconscious or I'm confused or altered mental status. So that's a very important distinction I want you to make in terms of neurologic findings, focal versus general. The reason it's so important is that a stroke, a classic ischemic stroke, is going to present 99% of the time with a focal neurologic finding, whereas ischemic strokes, your classic stroke, very, very rarely presents with a general neurologic finding such as altered mental status, confusion, seizure, loss of consciousness. Those things you're much more likely to see with a head bleed. And so it's very important to understand that just because your patient has an altered mental status, unless there's a focal neurologic finding, the chances that that's your classic ischemic stroke are very, very low. I work outside of Pinellas County in an emergency room, and I routinely get patients coming in as stroke alerts who are having general neurologic findings, and it's quite clear that they're not going to be your typical ischemic stroke in that situation. So it's important that you understand the difference and that you understand how that relates to what type of pathology you might be looking at. And again, motor versus sensory, it's important to distinguish whether the deficit is motor or sensory. I'd like to give us a clinical pearl related to neurologic exams, and this one is regarding delirium. So first of all, delirium is a transient or intermittent change in a patient's attention or cognition. We often see this in elderly patients. We see it probably 50% of the time in ICU patients, and some people would say up to 80% of the time in moribund patients. It's important because if you see this, estimates of mortality are up to 75%. So if you go to the nursing home and you pick up a patient that looks delirious to you, we need to understand that that's a key neurologic sign. It indicates a very seriously ill patient with a very high mortality. So just because grandma is goofy, we can't just assume that she's normally goofy. If grandma is truly delirious, that is having waxing and waning changes in her attention, having alterations in her cognition, that is an extremely serious sign and needs to be taken seriously. Okay, next is cardiovascular. The first thing you obviously want to look at with a cardiovascular exam is stability. Is the patient cardiovascularly stable? Is their blood pressure, pulse stable? Are they perfusing their brain? The next thing we want to be looking at is heart sounds. And yes, I know that this doesn't seem like something that necessarily paramedics ought to be doing, but yes, we should be listening to heart sounds, at the very least to regular versus irregular. You want to make sure that the audible heart tone and the pulse correlate with what you might be seeing on your monitor. Now, we talk about murmurs sometimes. We talk about it, but can you hear it? Can you recognize it? Most of us would probably answer no if we're being honest. I would suggest that there's probably one or two murmurs that would be very useful for you to be able to recognize, and those ones, it just so happens, are extremely easy to recognize. So we'll get into that in some later CMEs. The next one is capillary refill and perfusion. Again, just another indicator, particularly useful in children, but useful in anybody in terms of how well we're perfusing not only the central organs, but the extremities. And finally, here's a great picture of clubbing. That's a pretty extreme picture, but clubbing is very, very useful in terms of indicating a chronic hypoxic condition, which can either be from a cardiac condition or a respiratory condition. You're all obviously familiar with edema and cyanosis as findings as well. In the respiratory exam, we want to make sure that we're familiar with our sounds. It's worthwhile noting that wheezes are by definition expiratory and stridor is by definition inspiratory. Make sure you understand the difference between a rhonchi and a rail or a crackle. These are words we throw around a lot, and it's important that we're all meaning the same thing when we use these words. So take the time to review and make sure that you understand which these are, and we'll certainly come back to these when we talk in depth about the respiratory exam and differential diagnosis. Certainly also want to assess respiratory effort, whether there's any accessory muscle use, whether there's any retractions or paradoxical motion, and the respiratory pattern, whether it's regular, shallow, deep, whether it's slow or fast, whether there's a prolonged expiratory phase, which is certainly indicative of an obstructive respiratory pathophysiology as seen in asthma or COPD. You want to look for Kussmaul's or Cheyne-Stokes. Kussmaul certainly in a child should suggest possibility for DKA, and Cheyne-Stokes in a head injury obviously is a bad sign. Perhaps the most important thing I want to say about the respiratory exam is that respiratory rate is the first vital sign that changes in almost any type of abnormal condition, whether it's an infection where the respiratory rate has to increase to help support the metabolic demand of fighting the infection, whether it's a cardiac issue where the respiratory rate increases because we're trying to hyperoxygenate the blood or get rid of the CO2, whether it's a respiratory issue where we have a problem with diffusion of gases, the respiratory rate will increase to compensate for that. Almost any form of pathology and certainly any type of shock, the respiratory rate is probably going to be the first vital sign that increases. So it's really important to actually take the time to find a real respiratory rate and to make sure that you appreciate that a respiratory rate is an early indicator of sick patients. Next is the abdominal exam. We talk about a soft versus a distended abdomen. We don't always talk about what it means to have a rigid or peritoneal abdomen. And so we'll talk about that here in just a minute. Also certainly want to be looking for masses, even pulsating masses if you're thinking a AAA, whether you have abdominal bowel sounds, hyperactive sounds versus no sounds whatsoever. Certainly, certain types of intra-abdominal pathology produce different types of bowel sounds. The most classic one is probably a small bowel obstruction. You get a high-pitched tinkling type of hyperactive bowel sound. And then the appearance of the abdomen. Is there any discoloration? Are there any evidence of ascites or fluid in the belly? Are there skin changes indicative of liver disease, such as the old, what's referred to as the caput medusae, which is sort of distension of the veins underneath the skin of the abdomen. Looks almost like varicose veins across the abdomen. It's a sign of liver disease and cirrhosis. So all those things you want to check for. And I actually have Dr. Epstein from Bayfront to take us through a quick demonstration of an abdominal exam.
Pain for me. Okay. I want to just feel your belly and see how it is. How are your bowel movements?
Good.
They're good? No pain anywhere here, right?
Right around there.
Okay. How about down here
Right
now?
around there. Yeah.
Okay. And how about when I let go?
It hurts a little.
Okay, very good. I'm a little bit.
Okay, next is the GU exam. First of all, when to look. In males, we should be looking anytime there's suspected trauma to the region or a testicular torsion. In females, we should be looking when there's trauma, when there's significant bleeding, when there's an impending delivery or delivery prior to our arrival. You want to avoid direct inspection in cases of sexual assault unless required for one of the above. Also, always want to consider whether you need to have a chaperone with you there. I would say err on the side of caution and have a chaperone whenever possible. What are we looking for? Well, we're looking for external bleeding amenable to direct pressure and other means of control. We're looking for wounds that need to be dressed. And obviously, in the setting of childbirth, we're looking for presenting fetal parts, umbilical cord, prolapsed cord, and if a placenta has delivered yet, as well as if there's ongoing bleeding after the delivery. The skin exam. The color of the skin is something we should really be keying on. If they're pale, we should think anemia. If they're blue, we should think hypoxia. If they're yellow, we should be thinking jaundice. If they're silver or purple, which, yes, that happens, it could be from silver toxicity or long-term amiodarone use, believe it or not, turns your skin a silvery purplish. If they're orange, we should be thinking hyperbilirubinemia if it's a baby, which is sort of like baby jaundice. Or, in fact, if it's true, the old wives' tale, if you eat too many carrots or oranges, you can actually get your skin to be a sort of a shade of orange. And there's some other types too. There's a bronze discoloration that's associated with hemochromatosis or hyperpigmentation. So the color of the skin is something that we should really key on here. The temperature, obviously you want to be sensitive to the fact that the patient's skin temperature might be very high or very low. The turgor of the skin in terms of their hydration status and their overall health status, any rashes or lesions. Everybody should certainly know what a petechia or a purpura looks like. Hopefully you should know what scabies looks like for your own protection, as well as shingles. It's pretty embarrassing to declare the STEMI on the patient with chest pain. You bring him into the ER, the doctor lifts up their shirt and says, "Oh, look, it's shingles, cancel the STEMI alert." So you should want to know what those things look like as well. Obviously, we need to look for injuries, abrasions, tears, ulcers, and abscesses as well on our skin exam of the medical patient. And I'd also like to talk briefly about pressure ulcers or decubitus ulcers. Here's a grading chart. This is actually from one of the federal government websites, and it shows the 4 stages of decubitus ulcer. Now, we see this obviously mostly in our chronically ill older patients, but we'll also see it in patients who are quadriplegics or bedbound for any other reason. it is important that you have some idea of what the various stages look like and what the implications of those stages are. For instance, you want to make sure that you understand that once you get into the upper stages, active infection can be taking place, which can lead to sepsis. Also want to understand that the presence of these, particularly if they're not noted by caretakers, is certainly a clue as to the adequacy or safety of the environment of care. Next is musculoskeletal. You want to make sure you assess muscle tone, the range of motion of each of the extremities, and whether there's pain or limitation in range. You want to assess the strength of the extremities, whether there's any deformities, whether you see any injury patterns suggestive of abuse or other neglect. If the patient's able to walk, assessing the gait is always important. And, we talk about PMS or PMS intact or distal neurovascularly intact. We say this a lot, but what does it actually mean? So, we might touch somebody's fingers and say, "Can you feel me touching?" And they say, "Yeah." And we might do a cap refill and it looks like it perfuses pretty good, and we say, "Great." And we might say, "Squeeze my hand," and they can do it, and you say, "Okay, PMS intact." It's important that you actually document each of the components of that, and it's important that you have some familiarity with the various tests that are done for each extremity. The next clinical pearl is in regards to hip fractures in a dementia patient or any other patient who can't give you a reliable history. And the real question is, how do you assess whether or not there could be a fracture if the patient isn't a reliable historian or can't follow your commands? And there's a couple ways you can try and do this. One is you can look at the grimace or the facial expressions of the patient as you palpate the area. You can look for non-related signs of pain, tachycardia, guarding of the area. You can see whether they're able to bear weight on it or move it. You can look for evidence of local injury, redness or swelling to the skin, shortening or rotation. But the take-home point is that if you have a patient who's not reliable, who's not able to specifically complain of pain to an area, you really need to use other means to assess whether there could be an injury there. And if there's any evidence of an injury when you just look at it from an external, such as redness or swelling, you really have to have a high index of suspicion and treat it as though it's a fracture in these patients. Next is the psychiatric evaluation. It's important to have some idea of the difference between psychosis, hallucinations, and just general agitation. We all know what agitation looks like. Hallucinations can be auditory, they can be visual, they can be tactile. And I usually ask patients whether they see or hear things that just don't seem quite right to them or that other people don't see and hear. And patients often will answer you honestly, and they'll often give you a very clear indication of whether or not they think they might be having hallucinations. And psychosis is a sort of a broad term, but it refers to disorder in thought processes and things like paranoia. Let's talk about suicidal patients for a minute. We put a lot of weight on patient autonomy and patient rights, and correctly so in our society. However, there are times when we have to protect our patients from themselves. This is one of those times. I want to be clear about this because I think there's been some confusion. We should not be taking refusals on a patient that somebody else has reported to be suicidal to us. So if you have a family member that's telling you, "I think my family member took an overdose or might be suicidal," we should not then be talking to this patient and trying to figure out whether or not we believe the family member. I think the better part of valor in these situations is to simply take the patient to the emergency room, allow a physician who has the benefit of time and a controlled environment and laboratory tests, etc., to help make that determination. This is an area that we've made mistakes in the past. This is an area where we've had some bad outcomes in the past. And so I really want to caution you that if you have somebody who's telling you, who called us up and is telling you that they are worried for the safety of a patient, you should have really no qualms about making sure that that patient gets to the hospital to get an assessment. And obviously, if the patient's homicidal, we're certainly not going to leave them there. We're going to enlist law enforcement to help us get them to where they need to be. Here's the next clinical pearl, and it's regarding excited delirium. Now, sympathetic storm is the term that we use to describe this, and if you're not familiar with that term, it means sort of an overwhelming fight or flight response. It's an overwhelming stimulation of the sympathetic nervous system. It manifests as hyperthermia, tachycardia, tachypnea, tremulousness, or even seizure or altered mental status in its most extreme forms. It's seen with thyroid storm. It's seen with overdoses of sympathomimetic medications such as cocaine or methamphetamine. But it's also seen in a particular scenario involving a patient who's combative with the police, often been tased, often has polysubstance abuse, and it has a very high risk of sudden death associated with it. So the thing you need to be able to do is recognize this and realize that it's a life-threatening situation and that you can fix it and give a life-saving treatment, which is very simply a benzodiazepine to overcome the sympathetic storm. All right, we'll quickly cover some of our diagnostic tests. Our vital signs obviously are vital. The glucose we should check in anybody who we suspect having the possibility of hypoglycemia or hyperglycemia. We want to get rhythm strips and or 12 leads as indicated, and we want to measure end-tidal CO2s as indicated. I'm reluctant to say that any one of these things, aside from vital signs, should be done on every single patient because every patient is a unique situation. But it is important that we recognize what our diagnostic tools are in the field and when we should appropriately be using them. Just as an aside, there's an x-ray here, and the first person who emails me with what's wrong with this x-ray, I'll come up with a prize for. I'm not going to tell you what the prize is yet because I don't know yet, but we'll try and make it something pretty good. So the first person who emails me with what's wrong with this x-ray is the winner. Okay, so we've gone through how to take a history. We've gone through some basics of physical exam. We've gone through some basics of diagnostic testing. So if you remember, the point of those three things was to allow you to refine your differential diagnosis. So once you addressed your ABCs, you decided whether the patient was sick or not sick with the look test, you stopped and formulated your differential, and it was organized by most likely to least likely and most severe to least severe. Then you used your history, your physical exam, and diagnostic testing to gather information to either rule things in or rule things out from the differential, and allows you to refine your differential. Now, your refined differential diagnosis then helps you guide appropriate intervention. So, for example, you have a patient with chest pain. Now, I give you 3 different patients with chest pain. Now, I'll give you 3 different patients with chest pain, and you tell me which one you think should get aspirin and nitro, or if you think all of them should get aspirin and nitro. So here are the patients: a 19-year-old, 28-week pregnant female, a 54-year-old obese diabetic male, and a 32-year-old healthy male hit in the chest by a pitch. Now, the hint is, what's the name of Protocol C1? Well, the name of Protocol C1 is suspected acute coronary syndrome. Yet, we, as a system, have given all 3 of these patients aspirin and nitro, when clearly only the 54-year-old obese diabetic male should probably be getting aspirin and nitro. Remember that refining your differential, determining and implementing your treatment plan, again, should be a collaborative effort among all the clinicians that are caring for the patient, utilizing the concepts of crew resource management and teamwork so that we don't miss things, so that everybody's voice is heard, and so that we can get the most accurate and best plan together for the patient. Perhaps the most important thing to remember when you're refining your differential and implementing your treatment plan is that having a differential diagnosis allows you to tailor your history, your exam, and your diagnostic testing to the things that are on your differential. So rather than just applying the same shotgun approach to everybody, you've heard the term a focused exam or a focused history. The focused means I'm focused on ruling things on or off my differential diagnosis list. That's how you get to a focused exam or a focused physical, rather than having to do a full head to toe for every single complaint. Not to say that we should leave a ton of things out, and there should be some baseline exam that we probably do on everybody, but you should be able to focus in on the things that are most important to this patient's presentation and most important to help you rule things on or off the differential. Okay, the next is the transport decision. Remember that our overall goal is the right patient to the right resource at the right time. Make sure you review the destination protocol, which we'll show here. If you look at page 1, it tells you how to categorize the patients. And if you look at page 2 into page 3, it tells you how to choose the appropriate destination based on the color that the patient is. It's available on your tablet. It's available on the website. Please make sure that you're familiar with that protocol. Also, I think it's important to review what are some standard scene time goals for medical patients. Now, you've heard a lot of us talking about trauma scene times, but there are some sort of general goals for medical scene time as well. And these are this. In a known time-critical situation, such as a STEMI alert, stroke alert, etc., our scene time should be less than 10 minutes. That should be our goal. In any other medical patients, we should still be shooting for less than 20 minutes on scene. So not quite the same level of urgency, but really important to get off scene in a timely fashion and get the patient to the definitive care they need. The last thing I want to talk about is self-awareness in assessing patients. And this is an interesting concept. Really what it entails is learning and acknowledging your own biases. Now, we all have biases, and the only way to overcome them is to be aware of them, essentially to have self-awareness. And the purpose of this is to not allow your definition of normal or your cultural norms to color your interpretation of what's going on with the patient. I'll give you a couple of examples. In medical school, they taught us if you ever find yourself thinking, geez, I just can't stand this patient. I don't know why this patient is just getting under my skin. There's something about this patient. It's just, I can't stand him. They told us, stop, take a breath, and write down borderline personality disorder as your diagnosis for the patient, because borderline patients have a very sort of manipulative, unusual personality type that most people react to in a very negative kind of initial way. And so having that awareness of how the patient is eliciting a reaction in you and being able to be reflective about that and think about that and use that to your advantage rather than just deciding you don't like the patient is extremely valuable. The point is really to ask yourself why the patient is making you react the way you are. Here's another example. Some of you who have been through orientation have heard me talk about the progression of signs and symptoms of increasing intracranial pressure or worsening neurologic dysfunction as disoriented, irritable, combative, comatose, what we refer to as being a dickhead. And some of you have probably also heard me say in orientation, when you have a patient that you're talking to or examining and you find yourself going, geez, why is this guy being such a dickhead? That should actually make you stop and think, could this be increasing intracranial pressure or some other neurologic problem that's causing a deterioration in mental status to the point where the patient's becoming irritable or combative? And so, again, it's about asking yourself, why is the patient eliciting this type of reaction from me? And that's called having self-awareness as you assess your patients. It's a difficult skill. It requires some discipline, but it can be extremely useful in terms of finding out what it is that you're looking at with the patient. Okay, so this was not supposed to be a comprehensive review of how to palpate a pulse, how to take a blood pressure, where to put your stethoscope when you're listening to lung sounds. This was supposed to be an overarching theme of how you can approach assessing a medical patient. It involves using an organized approach. It has a template for the approach. We're actually going to start teaching advanced medical life support in the system here before too long. And my hope is that it will allow us to get better at formulating and refining differential diagnoses, allowing that to guide our focused or directed history and physical exam and our diagnostic assessments. Really, the goal here is to allow us to better assess our patients in order to provide the best possible care. As I mentioned earlier, we will get into specifics about assessing individual organ systems and complaints in future CMEs when we talk about high-risk chief complaints, when we talk about critical decision-making. But the purpose of this CME was to introduce the concept of an organized approach, formulating and refining a differential diagnosis, and a few key things in each area of the history, exam, and diagnostics. So I hope this was useful. Please give me any feedback on how we can make this better in the future, and be safe out there.